Good morning, I am Dr. SOWJANYA, Assistant Professor in Anesthesia Department. Today I will be discussing about local anesthetic drugs. So at the end of discussion, one should know about pharmacology of local anesthetics, mechanism of action, side effects, therapeutic uses of local anesthetic drugs. Local anesthetics, by definition, are the drugs that cause reversible loss of sensory perception, especially of pain, in a restricted area of the body when applied topically or local injection. Local anesthetic drugs, if applied to a mixed nerve, sensory and motor impulses are interrupted, resulting in muscular paralysis and loss of autonomic control. So the following slide shows the peripheral neuraxial blockade. Very good example is brachial plexus block, the central neuraxial blockade, and then the general anesthesia where the entire body gets anesthetized. History. If we date back to history, all local anesthetic drugs originated from cocaine, which is an alkaloid obtained from the leaves of Erythroxylum coca, first used as local anesthetic drug by Koller, who is an ophthalmic surgeon in Vienna. In 1884, he used the first local anesthetic on a patient with glaucoma. There is a general formula for all the local anesthetic drugs, that is an aromatic group joined to an amine group by an intermediate group which could be either ester or amide link. Procaine, which is an ester, first used in 1904. Lidocaine, which is an amide, first got introduced in 1940s. The following slide shows the list of local anesthetic drugs which are esters as well as amides. Chemistry, organic chemistry. The aromatic residue, which is the lipophilic one, gets attached to hydrophilic amine by a link which is an intermediate link which could be either amide or ester alkyl chain. Ester-linked local anesthetic drugs include cocaine, procaine, chloroprocaine, tetracaine, benzocaine. The amide-linked local anesthetic drugs include lidocaine, bupivacaine, libucaine, pilocaine, ropivacaine. There are a few differences between esters and amides. Esters have got short duration of action, amides produce longer duration of action. Esters produce less intense analgesic effect, whereas amides produce more intensive analgesic effect as they bind to alpha-1 acid glycoprotein in plasma. Esters gets hydrolyzed by plasma cholinesterase in blood. Amides, they are not hydrolyzed by plasma cholinesterase but in liver. Esters cause higher risk of hypersensitivity, so they are rarely used. Amides, they rarely cause hypersensitivity reactions. No cross-reactivity with ester local anesthetics. Esters are rarely used for infiltration anesthesia but useful for topical anesthesia on mucous membranes. Coming back to physiology, resting membrane potential. There is an electrical charge present across the membrane, which is the membrane potential. The resting potential occurs when the cell is not firing, which is 70 millivolts, which is the difference between the inside and the outside. Action potential. At rest, sodium channels and potassium channels remain closed, constituting about minus 70 millivolts. As soon as the fiber gets stimulated, when the cell firing happens, sodium channel opens, sodium influx happens, sodium ions enters into the cell, thereby potential increases. So the cell gets depolarized, sodium channel gets closed. So the potential becomes positive, that is plus 20 millivolts. Potassium channels opens and thereby potassium efflux happens. Potassium exits from the cell, thereby decrease in the potential happens. Fiber gets repolarized and sodium and potassium channel gets closed. Sodium potassium pump restores the balance. So the resting membrane potential comes back. So minus 70 millivolts it occurs. As a result, voltage gradient occurs along the axon, causing a current, which causes the configuration change in sodium channels in the next segment, leading to conduction. So the following slide shows a neuron where a small segment from the axon is being taken, and there is a plasma membrane where positive charge is present on the outside and negative charge is present inside, and microelectrode is present, one outside of the cell and the other one inside of the cell. Both the electrodes are being measured by voltmeter. This slide shows the action potential propagation. As soon as the cell firing happens, the propagation occurs from axon towards the dendrites. Okay, so as soon as the cell firing happens, the resting membrane potential, which is about minus 70 millivolts, it gets converted to positive. How it happens? By sodium channel opening and sodium influx occurs. So the negative to positive voltage happens, that is minus 70 millivolts, it comes back to comes to plus 20 millivolts, and then potassium efflux happens. As soon as the sodium comes in, the potassium efflux happens, that is at the depolarization. After depolarization, the potassium efflux happens, and then sodium channel closes, potassium efflux happens, and potassium goes outside, and cells get repolarized, and then both the channels gets closed, sodium potassium pump closes, and then the cell comes back to resting membrane potential, that is minus 70 millivolts. So first threshold occurs, that is firing. First resting membrane potential, depolarization, repolarization, hyperpolarization, and then comes back to resting. Coming to the mode of action, blockage of membrane depolarization in all excitable tissues, usually intended on peripheral nerve by membrane stabilizer. What do you mean by membrane stabilizing effect? The actions affecting the process of depolarization leading to failure of propagation of an impulse without affecting the resting membrane potential is known as membrane stabilizing effect. So the first ones to get blocked is the autonomic, followed by sensory, followed by motor. So motor will be the last ones will be blocked, and the autonomic nerves fibers will be the first ones to be blocked. If we talk about recovery, the motor fibers will be the first ones to be recovered first, followed by sensory, followed by autonomic. Effects of local anesthetic drugs. Injection. If we give an injection as an acid, hydrochloric salt, which is in ionized form, at physiological pH, it dissociates to free base, that is in lipid soluble. It passes through cell membrane to the interior of the axon, causing reionization, which enters and blocks the sodium channel, thereby preventing the influx of sodium ions. Thereby, no generation of action potential happens, leading to conduction blockade. If we look into the slide, without local anesthetic drug, the sodium channel goes inside. After the application of local anesthetic drug on the pain neurons, the sodium ion channels gets blocked. Thereby, no sodium influx happens. Thereby, no action potential occurs, leading to conduction blockade. Drug should reach nerve through tissue, which is the hydrophilic one. Drug should enter the nerve, that is neuron, that is lipophilic. Coming to systemic actions. When applied locally, gets into the blood, either absorbed from the tissues or accidental entry into the blood, which causes local anesthetic systemic toxicity, which we'll discuss further. Factors affecting the reaction of local anesthetics. Lipid solubility. All local anesthetic drugs are weak bases. Increasing the lipid solubility leads to faster nerve penetration, blocking the sodium channels, thereby speeding up the onset of action. The more tightly local anesthetics bind to the protein, the longer will be the duration of onset of action. Local anesthetics, they have got two forms, ionized and non-ionized. Non-ionized form can cross the nerve membranes and block the sodium channels. So the more non-ionized is presented, the faster will be the onset of action. Lipid solubility is an important characteristic. Potency is directly related to lipid solubility because 90% of the nerve cell membrane is composed of lipid. This improves the transit time into the cell membrane. pH influence. Usually pH is present in the range of 7.6 to 8.9. Decreasing pH, that is acidic pH, it shifts the equilibrium towards the ionized form, delaying the onset of action. Lower the pH, solution will be more acidic, gives slower onset of action. Presence of pus and inflammation will retard the action of local anesthetic, probably low acidic pH. Like we have discussed before, the lower will be the pH, solution becomes more acidic, gives slower onset of action. Presence of pus and inflammation will retard the action of local anesthetic drug, probably low acidic pH. Vasodilation. Vasoconstrictor is a substance used to keep the anesthetic solution in place at a longer period and prolongs the duration of action of the drug. Vasoconstrictor, it delays the absorption, which slows down the absorption into the bloodstream. Most commonly used vasoconstrictor is epinephrine, that is the adrenaline, as it prolongs the duration of action, as it keeps the anesthetic solution in place at a longer period, and it delays the absorption into the bloodstream. Therapeutic uses. Local anesthetic drugs can be used as surface anesthesia, infiltration anesthesia, conduction block, which could be either field block or nerve block. It can be used as spinal anesthesia, it can be used as epidural anesthesia, IV regional anesthesia, commonly known as Spear's block. Coming to surface anesthesia, amethocane, which is an ester group, can be used on eye, throat, urethra, rectum and skin. Benzocaine and lidocaine hydrochloride can be used for all the organs which I have discussed before, that is throat, urethra, rectum and skin, except for the eye. Procaine is unsuitable as surface anesthetic drug because of its poor penetrating power. Lignocaine can also be used as surface anesthesia. Coming to xylocaine or lignocaine, it is available in various formulations such as 4% topical solution, 2% jelly, 2% vials for injections with or without adrenaline, 2% viscous formulation, 5% ointment, 5% heavy for spinal anesthesia, 0.25 to 0.5% solution for epidural anesthesia, 10% spray for intubations, and 4% used for endoscopic exams. EMLA cream. EMLA cream is abbreviated as eutectic mixture of local anesthetic, which is a combination of lidocaine and prilocaine. It is mainly used for pediatric purpose. It can penetrate intact skin. It is used for IV cannulations, split skin graft harvesting procedures, other superficial procedures mainly 1 hour before. Eutectic means lowering of melting point of two solids when they are mixed. Coming to infiltration anesthesia. Infiltration anesthesia, their mechanism of action lies on nerve endings as exposed to the drug, thereby action. Procaine and lignocaine 2% are commonly used either with or without adrenaline 1:2 lakhs. Infiltrative anesthesia is mainly contraindicated where end arteries are involved. That is, the end arteries are mainly present in penis, digits, and also in CAD patients as well. Nerve block or conduction block. Nerve block, mainly a drug is injected close to the nerve or big nerve trunks. Example, brachial plexus block, sciatic nerve block, femoral nerve block, radial nerve block, ulnar nerve block. The following slide shows different nerves, either axillary nerve, which is part of brachial plexus, glossopharyngeal nerve, superior laryngeal nerve, median nerve. In these techniques, mainly the nerve is being blocked either by using ultrasound or landmark guided, anatomically landmark guided basis. Choice of drug depends on the type of surgery, whether short duration procedure or long duration, either lignocaine or bupivacaine or both together or with combination with opioids. Spinal anesthesia. Local anesthesia is mainly injected into the subarachnoid space, so it is also called as subarachnoid block. Injection is made heavy by adding dextrose or light by adding saline. When the anesthetic is injected outside the dura, this technique is called as epidural anesthesia. Lignocaine and bupivacaine are the two agents most commonly used in anesthesia practice. The following slide shows regional anesthesia techniques, that is spinal technique used in the patients in lateral decubitous position as well as sitting. And there is also a Taylor approach where needle is inserted paramedian. Complications of spinal anesthesia. Most common includes bradycardia, hypotension, headache, and rare complications such as cauda equina syndrome and septic meningitis happens. Epidural anesthesia. Here the drug is injected outside the dura like we discussed before. Drug spread is restricted to a specific region causing fewer complications. So this slide shows the epidural space anatomy, where an epidural anesthesia can be given cervical, thoracic and lumbar. In few orthopedic procedures for chronic pain therapy, the transforaminal epidural steroid injection is also being used. Coming to IV regional anesthesia, commonly known as Spear's block. The agent of choice for intravenous regional anesthesia is lignocaine or xylocaine. Here 20 to 40 ml of 0.5% lidocaine is used only for upper limb orthopedic surgeries. So this is a diagram, there is a picture showing the IV regional anesthesia where 20 to 40 ml of local anesthetic is being inserted. Coming to systemic actions, we have seen all the local actions of local anesthetic drugs. Systemic action when given IV, that is intravenous. Bupivacaine is relatively more cardiotoxic. leading to ventricular tachycardia or fibrillation. Lidocaine has little effect on contractility and conductivity, therefore used as an antiarrhythmic drug. The prominent cardiac action of xylocaine is suppression of automaticity in ectopic foci. When given by IV route, action lasts for about 10 to 20 minutes because of rapid redistribution. 1 to 2 mg per kg body weight is being given initially, followed by half of it every 10 to 20 minutes. Useful for only ventricular tachyarrhythmias. It is a class 1B antiarrhythmic. Here now we'll discuss about individual local anesthetic drugs: prilocaine, lignocaine, bupivacaine, ropivacaine, amethocane, oxethocaine. Prilocaine. Prilocaine is similar to bupivacaine, which is an amide link local anesthetic drug. One of the metabolites are very toxic, which causes methemoglobinemia. It is used for nerve blocks and IV regional anesthesia, so hence used cautiously as it causes methemoglobinemia. Lignocaine. Lignocaine is also known as xylocaine. It is most widely used amide-linked local anesthetic drug, most versatile anesthetic drug. It has got variety of applications like local nerve block, local injections, nerve block, spinal, epidural, IV regional anesthesia. When used locally, action starts within 3 minutes, which causes vasodilation. Overdose causes muscle twitching, convulsions, cardiac arrhythmias, fallen BP, that is hypotension, coma, and respiratory arrest. It is the most popular antiarrhythmic drug. It is a standard agent of choice for infiltrations, regional blocks, or topical anesthesia. It has got short onset of time, intermediate duration of action. It comes under class 1B antiarrhythmic properties. It has got medium toxicity. Maximum recommended dose is 3 mg per kg, 6 mg per kg with vasoconstrictor. That is adrenaline, which we commonly use. Coming to bupivacaine. Bupivacaine is also called as sensocaine. It is a potent, long-acting amide-linked local anesthetic drug available in India, most widely used all over. It is not at all used for IV regional anesthesia, but all others like local anesthesia, spinal anesthesia, epidural, everything. Blocks. Action lasts for about 2 to 3 hours. Strength for epidural, we use it as 0.25 to 0.5% solution. It has got high lipid solubility, therefore distribution will be more in tissues rather than in blood. Bupivacaine mainly causes more sensory block rather than motor block. The advantage taken in this is the same advantage taken in during cesarean section, that is walking epidural can be used. Bupivacaine is more prone to prolong the QT interval, thereby inducing ventricular tachycardia or cardiac depression, membrane stabilizing action. By the mechanism of membrane stabilization action, it causes cardiac depression. So toxic doses and accidental entry into vessel should not be used for IV regional anesthesia, as it causes toxicity and very difficult to treat when cardiotoxic happens with bupivacaine, where it requires high inotropic support. It has got the longest acting local anesthetic available in India now. Long duration of action is present in bupivacaine, no need for repeated doses. It is very hard to resuscitate, large doses of inotropes required, as we have discussed before. It is available in plain formulations as well as hyperbaric. Hyperbaric because varicity is being increased with the help of 5% glucose or dextrose. It is also available in levobupivacaine. It is a chirocaine, where it is less cardiotoxic, and newer formulation where liposomal bupivacaine is being used. Maximum recommended dose is 2 mg per kg. Coming to systemic toxicity due to same membrane stabilizing effect. Depression of function of CNS and CVS when high plasma concentrations are reached. CNS toxicity usually occurs before cardiovascular effects. First signs of excitation due to initial blockade of inhibitory pathways. Mild effects include circummoral tingling, metallic taste, tinnitus, visual disturbance, and slurred speech. Moderate effects include altered conscious state, convulsions. Later signs of generalized CNS depression with potentially fatal toxicity leading to coma and respiratory arrest, where we have to intubate the patient. Coming to serious toxicity, direct myocardial depression and peripheral vasodilatation occurs with the help of membrane stabilizing effect. Because of QT prolongation, everything will happen if bupivacaine being injected intravenously. For example, action potential duration will be decreased in ventricular muscle, thereby increasing PR intervals, QRS duration, sinus bradycardia, leading to sinus arrest, negative inotropy effect happens. Ventricular arrhythmias will occur, leading to ventricular fibrillation, difficult to resuscitate, especially with bupivacaine. So, reentrant type of tachycardia seen with bupivacaine, dose-dependent vasoconstriction or vasodilatation occurs. Coming to ropivacaine, a newer bupivacaine congener, equally long-acting but less cardiotoxic. Sensory block is more as compared to motor. So, this can also be used in walking epidurals. Continuous epidural ropivacaine is being used for relief of post-op and labor pain. So, it can also be used for nerve blocks. It gives shorter block, more differential block, that is reduced diffusion to large A beta fibers. Cardiac resuscitation is more successful as compared to bupivacaine. Maximum recommended dose is 3 mg per kg. Coming to amidocaine. Amidocaine is also called as tetracaine. Tetracaine is a potent and toxic ester-linked local anesthetic drug. It is hydrolyzed by pseudocholinesterase in plasma. It is useful for topical application to the eye, nose, throat, tracheobronchial tree, and rarely for spinal or epidural. Topical action is so fast as IV. Coming to oxazoxine, it is a potent topical anesthetic drug, unique in ionizing to a very small extent even at low pH values. It is therefore effective in anesthetizing gastric mucosa despite acidity of the medium. So it is very advantageous basically in patients with gastritis, gastroesophageal reflux and heartburn of pregnancy. So basically this drug is followed along with antacids, so providing symptomatic relief. Other side effects. So xylocaine, mainly it is neurotoxic. Sensocaine, it is mainly cardiotoxic, very difficult to resuscitate, so requiring high inotropic support as we have discussed, leading to ventricular tachycardia, reentrant type of tachycardia with bupivacaine. Membrane stabilizing action, because of its membrane stabilizing action, QT interval will be increased and action potential duration will be decreased. So local tissue toxicity such as neurotoxicity, mainly after continuous spinal injection with microcatheters. Transient neurological surgery after single shot spinal, rare. Other side effects continued. So allergic reactions common with esters like procaine caused by para-aminobenzoic acid, also found to cause arachnoiditis, less common with amides, where then mostly through preservatives. So drug interactions occurs like anticholinesterase, other competing drugs which are hydrolyzed by plasma cholinesterase. So attention must be implied whenever there is heavy sedation with anticonvulsants, as they may mask early signs of toxicity. So methemoglobinemia occurs whenever pilocaine is used in larger doses. And then comes the spinal additives, where sodium hydroxide and hydrochloric acid is being used, which affects the pH. Glucose and water is also used, which affects the baricity. Glucose for hyperbaricity and water for hypobaricity. Preservatives are also being used in multi-dose vials, not for subarachnoid or epidural use. And then comes the vasoconstrictors, that is epinephrine and philipressine, where the duration of action is being prolonged and where the anesthetic is being placed in that position itself. And then comes the CO2, that is carbon dioxide, which very speed onset of blockade occurs by decreasing the intercellular pH. And then there are certain opioids like fentanyl and butyrophenol, where it prolongs the duration of action. Thank you.